Ladies and gentlemen, thank you for joining us for this installment of the NIOSH Total Worker Health webinar series, A New Look at the Way We Work, Non-Standard Work Arrangements and Their Impacts on Worker Safety and Health. Our presentation will now begin with an introduction from Dr. Casey Chosewood.
Well, good afternoon, folks. Thanks, Reed, for your kind introduction and the lead-up remarks today. As Reed said, my name is Dr. Casey Chosewood, and it is my pleasure to welcome all of you to the next installment in the NIOSH Total Worker Health webinar series, A New Look at the Way We Work, Non-Standard Work Arrangements and Their Impacts on Worker Safety and Health. You're really in for a treat today. We have a selection of wonderful speakers. First, we're going to hear from Dr. Rene Pana-Cryan, and Dr. Pana-Cryan is the Director of the Economic Research and Support Office in the NIOSH Office of the Director, and she co-manages the new Healthy Work Design and Wellbeing Cross-Sector Program. Rene joined NIOSH in 1996, and her current interests include applying standardized methods to assess the broad impact of worker injury and illness to workers and their families, to employers, and to society as a whole. And she's dedicated to improving our understanding of the impact of economic factors on the incidence and severity of worker injury and illness. Most importantly to me, Rene is a spirited and skilled colleague. Welcome, Rene, to today's webinar. After Rene, we will hear from Dr. Sherry Barron. Dr. Barron is an occupational physician and researcher and is a professor of occupational and environmental health at the City University of New York's Barry Commoner Center for Health and the Environment. She was the principal investigator for a collaborating center of the CDC-funded Workplace Health Research Network. And Sherry's research focuses on documenting health and safety exposures and developing intervention programs for low-wage and immigrant workers in New York City. Finally, after Dr. Barron speaks, we'll hear from Dr. Lisa Brosseau. Lisa is a professor at the University of Illinois at Chicago, where she directs the Illinois Education and Research Center and the Center for Healthy Work. Her research interests include respiratory protection, with a particular focus in healthcare settings, and a focus on the design and delivery of workplace health and safety interventions in small businesses. These are three exceptional speakers today, and we're delighted to have them all with us. So just a few introductory remarks before we hear from our speakers. Most of you are old pros when it comes to total worker health, and you already know what our definition is. But basically, total worker health is defined as policies, programs, and practices that organizations have the power to put into place that not only protect their workers from work-related safety and health hazards, but also promote injury and illness prevention more broadly, with the goal at the end of the day of advancing worker well-being. And see, these outcomes are great for individual employees, they're great for individual workers, they're also good for employers and organizations, they're good for our families, they're good for the nation's economy and for individual and collective productivity. We believe that the total worker health approach that is connected, that is collaborative, that really moves people along a continuum to better working conditions is really a necessary solution for a healthy individual, healthy organization, healthy communities, and a healthy economy. The Total Worker Health Program is part of a larger research agenda that NIOSH has inspired. Many of you on the phone have heard of the National Occupational Research Agenda, and NORA is a partnership, if you will, really designed to inspire and stimulate innovative research and improve workplace practices that meets the needs of our nation. And while this is inspired by NIOSH, really the NORA approach is really meant for all of us collectively to advance research in our own setting, whether that be an academic institution, whether it be our own place of employment or a labor partner. There are many ways that partners can work with us to advance the necessary research needed to continue to improve the way we work in our country and around the world. Now, one of the components of the NORA is that it's divided into a number of industry sectors, actually 10 of them, that are based on the major areas of the U.S. economy. It's also sort of crosswalked with 7 different health and safety cross sectors. And these are organized to major health and safety issues that are affecting the U.S. working population. And NORA is now in its third decade, and one of the 7 cross-sectors that is new for the third decade, we in the Total Worker Health Program are happy to be part of. And that is a new cross-sector entitled Healthy Work Design and Well-Being. And as I mentioned, this is the newest and the 7th cross-sector within the National Occupational Research Agenda. And the topic of non-standard work is front and center on the research, really the research mind and focus of this new cross-sector. This program really brings together the joint efforts of 3 previously existing programs within NIOSH. One, of course, the Total Worker Health Program. Second, the NIOSH Economics Program that is led by Dr. Pana-Cryan and from whom you'll be hearing in just a bit. And then lastly, the NIOSH Work Organization and Work Stress Prevention Program, which is now led by Dr. Naomi Swanson. Combining the efforts of these 3 groups has already shown a tremendous amount of synergy for moving forward this topic of healthy work design and well-being. You can see what our mission is here, and our goal really is to strongly partner with all of you, with industry, with labor, with trade associations, academic institutions, and professional organizations to better understand the ways that we can design work with health endpoints in mind. And that really is at the heart of the goal of this new cross-sector. Well, let's move on to our topic for today. So as we look at the new way we work, there are really 4 key objectives that I'm convinced we will be able to tackle. First, you're going to hear from Dr. Pana-Cryan talking about common categories and determinants of work arrangements. We're going to explain why we need a better taxonomy of work arrangements to conduct research and understand the health and safety challenges in this arena. I hope that you'll leave with an understanding of the safety, health, and well-being impacts of non-standard work. It might surprise some of you to know that almost all net job growth in the nation in the past decade has been what most would consider non-standard employment. And then lastly, we'll explore the rationale for a total worker health focused interventions for those who find themselves in non-standard jobs. So with that, let me welcome our first speaker for today's webinar, Dr. Pana-Cryan. Welcome. Please take it away.
Thank you, Casey. So today I will be talking about defining non-standard work arrangements from a NIOSH perspective. Workers in standard work arrangements include regular permanent employees. So these are workers in traditional arrangements who often have access to employer-sponsored fringe benefits. Examples would be paid sick leave and health insurance. The numbers of workers in work arrangements that are not standard seem to be increasing. The types of non-standard arrangements also seem to be increasing. So we are interested in non-standard work arrangements because workers in these arrangements may be exposed to more safety and health risks than workers in standard arrangements. They may also suffer lower levels of well-being. The work arrangement terms that are commonly used are broad and lack standardized definitions. So a better understanding of the characteristics and types of work arrangements will help us to better understand the relationship of these arrangements with health, safety, and overall well-being outcomes for workers. So the new NIOSH Healthy Work Design and Well-Being Cross-Sector that Casey introduced to you is focusing on non-standard work arrangements. We aim to understand the determinants and consequences of these arrangements in order to develop and implement, eventually, interventions to improve the safety, health, and well-being of workers. To start a systematic efforts on this topic, we convened a work group in late 2016. And in the following slides, I will go over our foundational taxonomy and research efforts. So in terms of taxonomy, in late 2016, an article by our director, Dr. John Howard, discussed 3 broad types of non-standard work arrangements, and I will briefly tell you about this. So the first type is agency work. This is a co-employment or joint employment arrangement. where an agency labor supplier hires employees for temporary work assignments at the premises of another employer. The agency labor supplier often pays for wages and insurance, such as unemployment and workers' compensation. In this arrangement, both the agency labor supplier and the host employer share legal responsibilities for protecting the safety and health of employees. The second broad type of non-standard work arrangements is contract work. And in this arrangement, workers provide services to a firm as part of a business, not employment relationship. Independent contractors are not legally recognized as employees and are excluded from federal labor law protections. The third broad type of non-standard work arrangement is gig work. In this arrangement, workers connect with customers by means of mobile technology mediated by the internet. While some gig workers may be classified as independent contractors, others may be considered employees of a new type of employer, and that would be the online job platform. A fourth broad type of non-standard work arrangements includes volunteer work. Workers in these arrangements are unpaid, but they perform work managed by others and are exposed to risks similar to those that workers in standard arrangements are exposed. So we're interested in that category of workers as well. So I told you about 4 broad types of work arrangements based on employment or business relationships. However, these types of arrangements are not common in current data collections, or consistently used in current data collections. Instead, common categories of non-standard work arrangements include the following 4, as you can see. Independent contractors who, unlike what I previously told you, sometimes actually identify themselves as being employed in national surveys. Next, we have on-call workers, which is a category that was not identified in the 4 broad clean-cut types that I mentioned previously. Then we have workers paid by a temporary agency, and that would be the agency worker previously mentioned. And last, we have workers whose employers contract their services out to another employer. So as I told you, in healthy work design, we are trying to better understand taxonomy and to do some foundational research on the topic. So in order to make sense of both the theoretical and practical aspects of the taxonomy of work arrangements, the Healthy Work Design and Wellbeing Work Group is constructing descriptors of work arrangements based, of course, on the literature, and based on existing data sources, and based on known and potential associations between work arrangements and health and safety outcomes. So broadly, a work arrangement involves a patterned relationship between work and work rewards. And common ways of identifying and describing work arrangements include rate of pay or income, access to fringe benefits, the work schedules, opportunities for advancement, the length or term of employment, and degree of job and income security. So we believe that we should include the self-employed because sometimes the distinction between being employed or self-employed is not clear. Because, of course, the self-employed often have important safety and health issues, and because the self-employed often face arrangements that are similar to those imposed by employers. An example would be arrangements imposed by online platforms, and that would be, the gig work that I previously mentioned. Another important issue is the consideration of workers' overall work arrangement, and that is actually pretty hard, but we appreciate that this is the way we need to look at this. So we're not interested only in the main job, but all the jobs held at one time. we should consider all jobs held at one time. In addition, we should consider patterns over time. As workers experience periods of unemployment or transitioning from one job to the next. So in this table, you see our proposed taxonomy. Columns include the categories of those who are employed, those who are self-employed, and those who are volunteers. And then the employed may be permanent, temporary, or interns, while the self-employed may have their own business or not. In the rows, we have listed the characteristics of work arrangements, and these include job security, work schedule, compensation type, pay level and security, benefits, and that would be the fringe benefits, and single versus dual or multiple employers. So here we have listed a few common data sources, key data sources. So the first one is from the Bureau of Labor Statistics, and it is the contingent work supplement to the current population survey. The last time this was conducted was 2005. The next one is a RAND work survey, and you can find a lot of good information in this seminal publication by Katz and Cougar. So I will be calling this RAND 2015. And in that article by Katz and Cougar, you can also see comparisons between the CPS from 2005 and, of course, the RAND 2015. The next one is a NIOSH-sponsored survey. This is the Quality of Work-Life module of the General Social Survey. Next, of course, we have the National Health Interview Survey that I'm sure some of you are very familiar with. And we have supplements for 2010 and 2015. And all the sources that I listed use the categories that I talked about before that include independent contractors, on-call workers, temp workers, contract workers, and of course the workers in standard arrangements. In 2015, the National Health Interview Survey kind of lumped together the temporary and contract workers in one category that I think I refer in later slide as Temp Plus. And there's no on-call category listed separately, but there is a catch-all category of other arrangements. Lastly, there is a recent report by Pew Research Center that provides information about workers who earned money from an online job platform in the previous year, and the survey was administered in 2016. So what do we know about the prevalence of non-standard work arrangements? I think others after me will also mention specific topics on prevalence, but here I have just some basics in terms of the sectors that show up in mostly, in non-standard arrangements. So from the National Health Interview Survey, we know that non-standard arrangements were most prevalent in services, construction, healthcare and social assistance, and that will be for 2010. And for 2015, they were more prevalent in services, construction, again, you see the same, but third comes wholesale and retail trade. Katz and Cougar mentioned that the highest shares were in services, agriculture, construction, and transportation and warehousing in both 2005 and 2015. And the highest increases in these shares from 2015 to 2005 to 2015 were in agriculture, services, education and health services, manufacturing, and mining. Lastly, the Pew Research Center mentions that 8% of U.S. adults earned money from an online job platform in the previous year. Remember, this was administered in 2016. And 29% of those adults considered this income essential for meeting the basic needs. So, in other words, a little over 2% of adults. So now I will tell you a little bit about the research we're doing, the foundational research we're doing. So we have been looking at how work arrangements affect job stress and health-related quality of life. You can see a recent publication. I added the link for a recent publication here. We have work in progress on the relationship between non-standard work arrangements and earnings and benefits, as well as financial stress. And I have added some links to abstracts that we have currently submitted and accepted for a recent conference, Workstation Health, and so you can find the abstracts at least on the web. And we also are interested, of course, in developing a research agenda on this topic. So again, in terms of research, we're doing some foundational efforts, and we are aiming to develop a research agenda on this topic of non-standard arrangements. So now I will tell you a little bit about these three pieces of work that I mentioned. So the first one is about job stress and health-related quality of life. Again, we're using the Quality of Work Life survey. We're using data from all 4 years that the survey was administered, and you can see that the question is, how would you describe your work arrangement in your main job? And then we have the 4 categories in terms of answers that people self-selecting. The health-related quality of life question has 4 parts. The first one is about general health. The second one is about physical health. In other words, how many of the past 3 days was your physical health not good? And then the next question, the third one, is about mental health, similar structure with the one on physical health. And the last one is, again, with similar structure, about usual activities or activity limitations. So the responses to questions 2 and 3 that are about physical health and mental health are summed together to produce what we call the number of unhealthy days. And the responses to question 4 assess days with activity limitations. And as you can imagine, some of these types of days where people don't feel healthy or people feel like they have activity limitations would affect productivity. That is part of our interest in that, and of course in the overall well-being of workers. So some of the results, first in terms of the effect of work arrangement on the perception of job stress. We found that compared with workers in standard arrangements, independent contractors and on-call workers were significantly less likely to be stressed. The results we got for the other categories of non-standard arrangements were not statistically significant. In terms of the effect of job stress on unhealthy days and on days with activity limitations by work arrangement, we found that among independent contractors, those who were stressed were almost twice as likely as those who were not stressed to experience unhealthy days. Now remember, here we're comparing stressed and non-stressed independent contractors. The comparison is still within the category of independent contractors. So the ones who are stressed are almost twice as likely to experience unhealthy days. In the same way, among temporary agency workers, those who were stressed were more than 5 times as likely as those who were not stressed to experience days with activity limitations. So these 2 pieces together tell you that work arrangement matters in terms of the job stress experience, and it also tells you then that work arrangement matters in terms of differences in how workers in different non-standard arrangement categories do in terms of unhealthy days and activity limitations based on whether or not they're stressed or not stressed. The next study that I mentioned is still a work in progress, and we used the National Health Interview Survey from 2010 and 2015. And remember now, these have 4 categories instead of 5 or 3 non-standard categories. That would be independent contractor, temporary plus, and other. And for independent contractors, we had information about self-employed versus employed. You can also see that the dependent variables are earnings, family poverty status, access to health insurance, and access to paid sick leave. So we found, as expected, that workers in non-standard arrangements were paid less, they were more likely to live in poverty, and they were less likely to have access to health insurance and paid sick leave. And then we also found differences between types of non-standard work arrangements. The third study is about the association between non-standard work arrangements and financial stress. So we had several questions. You can see the detailed questions in the listed bullets. But basically, they covered different categories of financial stress that included medical, basic, standard of living, and retirement. So in other words, do you worry about having enough money for retirement? And you can see that people had 4 categories of worry to pick from, ranging from very worried to not worried at all. And we found that compared with workers in standard arrangements, workers in non-standard arrangements were more likely to be very worried about all 4 categories of worries that we examined. So medical, basic, standard of living, and retirement. So to wrap up, in terms of taxonomy, having a better understanding of clear-cut, a better understanding of characteristics and categories of work arrangements would help us facilitate, the selection and design of survey questions. It would facilitate more focused research where work arrangement needs to be documented or used as a variable of interest. Would assist in reducing the confusion surrounding general terms referring to work arrangements. And in terms of research wrap-up, we know that non-standard work arrangements are understudied, but they're increasingly prevalent. And we understand some, but not all of the determinants and consequences of these work arrangements. So I already told you that research is needed on specific categories of non-standard work arrangements. So it's not enough to clump all the non-standard workers together in one category. We need more detail. And to meet the need of specific stakeholders, research should be conducted in ways that are specific to certain industries and occupations. I told you a little bit about the different prevalence and changes in that prevalence in terms of industries. And particularly needed are models of the determinants and consequences of work arrangements so we can make sense of all this in a holistic way, as well as ways to link databases that will allow us more holistic research efforts. This concludes my presentation. Thank you. And your next presenter is going to be Dr. Sherry Barron.
Thanks. Dr. Pana-Cryan just gave us a very comprehensive overview of the research on the size and health impacts of non-standard employment. In my presentation, I'll first underscore the importance of just a few of the patterns we see in these data. Then I'll focus on some approaches we as occupational health researchers and practitioners might use to develop new and better total worker health programs that meet the needs of non-standard workers. One of the studies that was just presented looked at the growth of non-standard employment over 10 years. And those authors summarized their findings in this way, and Dr. Chosewood mentioned this at the beginning of the talk. They say all of the new employment growth in the U.S. economy from 2005 to 2015 appears to have occurred in alternative work arrangements. So I think that statement alone makes it clear why this topic is so important. I'd like to emphasize a few additional important points from their findings. First, 2 demographic groups stand out as experiencing disproportionate growth in non-standard employment: older workers and women. In 2015, almost 1 in 4 older workers were non-standard workers, and women are now as likely as men to be a non-standard worker. For both of these groups, there may be additional health issues to consider. For some older workers, this provides welcome flexibility, but for others, it may place them in new work environments where physiologic or cognitive factors could increase their health and safety risk. Similarly, women may seek non-standard employment either because they need flexibility or are newly re-entering the workforce. In both of these cases, this is often the result of their disproportionate responsibility for children and elder care. This double duty they assume as workers and caregivers may exacerbate the inherent stress associated with non-standard employment. And the reality is that many of these jobs lack access to health care, sick leave, and other benefits that are extremely important to workers who are also caregivers. The growth of non-standard employment is affecting a wide spectrum of workers. You can see here that many higher-paid professional workers, like those working in computers, legal, and education and training, have all experienced a substantial shift into non-standard employment. Now close to 1 in 5 are non-standard workers. There are also many lower status workers in non-standard employment, and many of these workers are employed by small businesses or in isolated situations such as home health aides, community social service workers, or truck drivers. Both the known health risks associated with their employment and their isolated locations make reaching them with workplace programs particularly challenging. Regarding data on health impacts, existing statistics show occupations that have been and still are disproportionately non-standard also have some of the highest injury and illness rates, making them high priority for interventions. As you can see here, the top occupations for fatal injuries are farming, construction, and transportation, and all are disproportionately non-standard. Also, some of the lowest wage occupations, such as those seen here, have experienced the highest non-fatal injury and illness rates and are also disproportionately non-standard. A central characteristic of many non-standard jobs is that they create a feeling of job instability, which researchers have measured as workers reporting that they are worried about becoming unemployed. A large national study found that those reporting job instability were 43% more likely to also report fair or poor health. They also had an increased risk of unhealthy behaviors associated with chronic diseases such as obesity, inadequate sleep, and smoking. So it is clear that many workers employed in non-standard jobs are the workers most in need of programs aligned with the total worker health vision. The most important way to protect non-standard workers is to address any ambiguity over who is responsible for protecting their health at the worksite. Temporary or contract workers must be afforded the same level of training and access to health programs as permanent employees. Under the previous administration, the head of OSHA, Dr. David Michaels, was very clear and proactive on this point. The importance of worker participation in developing programs has been emphasized by several reviews of total worker health research. And this commitment to worker participation in design of workplace programs needs to be central, whether addressing standard or non-standard workers. There are many resources on worker participation in total worker health programs, but I direct you to this NIOSH Center of Excellence, where they have an excellent toolkit to promote worker participation in program design. However, many non-standard workers are employed in isolated workplaces or work alone. Many work for small employers who lack the resources and sometimes the commitment to develop comprehensive health programs at the work site. Thus, limiting total worker health programs to the work site alone will likely mean that an important portion of the working population is excluded. and doing this could potentially lead to broadening rather than reducing health disparities. As occupational health practitioners, we're accustomed to collaborations between, for example, doctors, industrial hygienists, and ergonomists. But to accomplish a more inclusive total worker health vision for non-standard workers, we'll need to develop new kinds of collaborations. So how and with whom? So next, I'll provide some of my perspectives on potential collaborators. Healthy People documents have been the major goal-setting process for the U.S. public health programs. For each decade, starting in the 1980s, a set of goals were developed and tracked. Since it began, each subsequent decade of the Healthy People reports tells a story of a shift from a focus on individual health behavior change to an increasing interest in the environments and the economic, social, and political conditions that shape health. This is now known as the social determinants of health. Today, it's more commonly recognized that work is important to health, not only for the income that work generates for families, but as a broader social determinant of health. And this provides new opportunities for collaboration to reach non-standard workers. Public health practitioners use the social ecological framework to develop interventions on the social determinants of health. This framework stresses the importance of developing and coordinating interventions targeting multiple levels of influence, including at the individual, interpersonal, institutional, community, and policy levels of influence. The social ecological framework argues that to be effective, public health intervention programs need to use approaches at all of these levels. In a worker context, the social ecological framework is particularly relevant for understanding how one major social determinant, employment and work, is impacted by all of these levels of influence, and it points to new types of collaborators beyond the work site. Recently, the Total Worker Health Program developed a new schematic modeled on the Occupational Safety and Health hierarchy of control model that you see here. This hierarchy emphasizes that it is always important to implement higher level controls like elimination or substitution of hazards before adopting less effective solutions like use of personal protective equipment. Now here is NIOSH's hierarchy of controls applied to total worker health, with specific actions at each level of the hierarchy. What I found remarkable when I first saw this on the NIOSH website is how well it coincides with the language of the social ecological framework. And this creates a common language for creating collaborations with others in public health, especially to bring the total worker health vision to non-standard workers. Here you see the same ideas and words, but embedded in the social ecological framework. So now let's look at some specific approaches to collaborations with the social ecological framework in mind. The first example is collaboration with state and local health departments. They are key partners with the federal government to achieve healthy people objectives. Public health agencies are in a position to intervene at multiple levels of the social ecological framework by shaping policy at the workplace and in the community. NIOSH has recognized this and has supported over half the state health departments to develop occupational health surveillance and intervention programs. Recently, 21 state health departments, in a coordinated effort with NIOSH, added questions on respondents' occupation as part of the behavioral risk factor surveillance system. This survey generated rates by occupation group for the American Heart Association's Life Simple 7, a metric of cardiovascular disease risk. This survey found that 2 occupations had especially high rates of cardiovascular risk factors: transportation and material moving workers and community and social service workers, both of which are occupations that are disproportionately non-standard, and many of these workers also work in isolated work environments. State and local health departments can use this information to expand current efforts, such as in Massachusetts, they included workplace stress reduction in the statewide strategic plan to address cardiovascular disease. State and local governments are also in a position to act on data to implement policy changes. Here are two recent examples of New York City policies that improved working conditions for non-standard workers. The first was a mandatory paid sick leave policy, and the second is legislation to protect against wage theft for freelancers. We recently did an evaluation of the awareness of the paid sick leave law in New York City among restaurant workers and found that worker awareness was tied to the efforts by government agencies to partner with community organizations who actively participated in spreading information to communities beyond just providing information at the work site. The next type of potential collaborators involves primary care practitioners. Though training for primary care practitioners emphasizes attention to the social factors that influence health, research suggests that primary care practitioners sometimes underestimate patients' social needs, including work-related needs. Advances made possible by electronic health records have created new opportunities. Health informatics researchers have called for expanding the social history to ask patients about their occupation, as well as about hours of work, job stresses, and concerns about work. Using new tools within the electronic health record, such as clinical decision support, can help to identify work exposures affecting health and can support improved collaborations and coordination between primary care and occupational safety and health practitioners. I've been working with NIOSH researchers in collaboration with occupational health clinicians and health informatics researchers to investigate how clinical decision support tools could improve the way primary care practitioners approach patients' work-related concerns. These tools and other resources will be available soon in a special issue of the Journal of Occupational and Environmental Medicine. Another potential collaboration involves community-based organizations and the use of community health workers. Community health workers are generally members of the same communities that they serve and are seen as trusted sources to provide health support services. They're employed by community health centers, hospitals, and community-based organizations. The community health worker model has been used in a variety of intervention programs, including some programs that deliver workplace safety and health education in community settings for hard-to-reach workers in non-standard jobs. Here's one example. Following Superstorm Sandy in the New York City, New Jersey metropolitan area, we at Queens College set up a program in collaboration with a community-based organization. We knew from previous natural disasters that day laborers working in non-standard arrangements involved in the cleanup and reconstruction efforts would be unlikely to receive training or protective equipment. Using someone from the community who acted like a community health worker, the program provided training and personal protective equipment to more than 500 Latino day laborers. In follow-up telephone interviews, we found that almost half reported that following the training, they raised questions with their boss about health and safety risks, and about a third refused to do a task they thought was too dangerous. In focus groups, we heard from workers that the information provided gave them the confidence or the self-efficacy to speak up in the workplace. So this example demonstrates how community health workers can address work issues in a community context. Most community health worker training programs include little or no information about the role of work on their patients' health. To address this gap, we developed a training module called Working with Workers, Talking About Workplace Safety and Health. It provides community health workers basic knowledge such as how to start a conversation about workplace exposures, how to identify workplace hazards, how workplace exposures contribute to disease, health and safety rights of workers, and action planning. We've tested the module as part of several cohorts of a 3-month community health worker training program. Here's one of the case studies included in the training to give you an idea. Maria is a 50-year-old woman working as a temporary worker at a mail-order warehouse. If she fails to fill the daily quota of orders on more than 4 days, she'll be fired. Her second week of work, the weather became hot and she was not able to work fast enough to keep up with the quota. Determined not to be fired, she worked faster, so by lunchtime she was sweating and nauseous. She wasn't hungry and decided to work through her lunch break. Soon after, she collapsed at her workstation. The module then explores with the students questions like, what caused Maria's nausea? What kinds of questions might best elicit the information about work risks? And most importantly, what information or referrals they could provide to workers like Maria so that she could take action to protect her health. So in summary, non-standard work is increasing and has health impacts. Worksite interventions need to be inclusive of all workers in the worksite. But to be inclusive of hard-to-reach workers, the social determinants of health and social ecological framework provide opportunities for new kinds of collaborations. Finally, I'd like to acknowledge my collaborators from New York University, the CUNY School of Public Health, and others at Queens College. Together, we were one of the collaborating centers of the Centers for Disease Control-funded Workplace Health Research Network, and many of the ideas and results I presented here came from that work. Thank you.
Great. Thanks very much, Dr. Barron. Now we're ready for Dr. Brosseau. Welcome to the webinar, Lisa.
Thank you. So that was a great lead-in, and I'd like to thank NIOSH and in particular Reed and Casey for arranging and hosting this webinar. So I'm going to talk a little bit about the Center for Healthy Work. The Center for Healthy Work at the University of Illinois at Chicago is one of now six NIOSH-funded centers of excellence for total worker health. Our focus in Chicago is specifically on the development, testing, and dissemination of interventions aimed at improving the health of people in precarious jobs. I'm going to use the word precarious, although because that is the word we've been using in our center, although it does mean largely the same thing that the previous two speakers are talking about in terms of non-standard work, particularly for the more vulnerable workers in those categories. Because many such jobs occur in workplaces that are hard to reach via their employers, we are using community engagement approaches similar to those described by Dr. Barron. My interest in total worker health for this population stems from my work over more than 20 years with Dr. David Parker at the when I was at the University of Minnesota. We evaluated the effectiveness of workplace health and safety interventions in numerous small businesses. And more recently, I conducted a study with Dr. Deborah Henricus, which was a randomized controlled trial of an integrated workplace safety and smoking cessation intervention in 47 small manufacturing businesses. This latter study was informed by Dr. Gloria Sorensen's early total worker health research, and it was also motivated by very high smoking rates among manufacturing production employees. We expected that improvements in workplace safety made by businesses in the intervention group would contribute to greater use of smoking cessation products, more quit attempts, and more successful quits when compared to the control group. Using a delayed intervention design in year 1, we conducted our intervention activities in half of the businesses, and in year 2, the control businesses then participated in the intervention. At baseline, employees were surveyed about workplace safety problems and were asked to make suggestions for improvement. Managers and safety committees were then encouraged to select and address at least one of these problems. Managers received training on smoking addiction and best practices for supporting smoking cessation. Smokers were invited to participate in small group discussions, given smoking cessation product samples and a 2-week supply of a product of their choice, and offered resources on quit lines and coaching. We also offered tailored newsletter articles and other resources at each of the participating sites. We are currently preparing a publication describing the outcomes of this study, but I can share some very preliminary results, which suggests that there were no differences in the number of smokers or quitters in either group at follow-up. But we did find some other successes. We were successful in motivating pretty much every company to make at least one workplace safety improvement. And our intervention sites did show significant improvements in the safety climate scores. As well, more smokers in our intervention businesses reported using smoking cessation products. On the other hand, we did encounter a number of challenges, several of which I think are relevant to the topic of this webinar. In many of our enrolled businesses, there were employees working in the production area who were not invited to participate in this study. And in retrospect, I now understand that these were probably temporary or contract workers who were not considered part of the permanent workforce. Because they were excluded, I can't tell you much about their demographics or smoking rates. As well, we encountered a lot of problems in scheduling meeting times with smokers, many of whom were allowed to take only the minimum 2 daily 20-minute morning and afternoon pay breaks, and who thus often worked through their lunch periods because that was an unpaid period. As well, many of the production managers would not accommodate or were reluctant to accommodate our requests for additional release time for employees. And after we analyzed the baseline data, it was clear that this may have been at least partially due to the fact that the smoking rates among production managers were almost as high as among the production employees, which suggests to me that production managers could have been our first or maybe even primary target of intervention, since they clearly were serving as important gatekeepers. So what's happening? And why do we see the increase in such a large number of non-standard workers? Drs. Pana-Cryan and Barron both discussed this rising number of people in non-standard work arrangements in all economic sectors. If you look back towards the beginning of the century and the latter part of the 19th century, the last century and the latter part of the 19th century, what you see is a corporation model that used a standard employment arrangement, which generally contributes to a stable workforce with good wages and benefits for everyone in the corporation and generally everyone in the economy. So what's changed from that? Just as changes in technology contributed to the Industrial Revolution toward the end of the 1800s and early 1900s, technology changes in the latter half of the 1900s, such as such as computers and the internet, have made it easier for companies to control their supply chains over longer distances. So this allows businesses to focus on their what is called core competencies, which means that they're no longer managing all of their functions internally. A very good book I would recommend reading is by Dr. David Wheel, where he describes this and coins the term the fissured workplace. And as I said, I strongly recommend reading this. He does a very nice job of describing the historical and underpinnings for the movement towards a fissured workplace and more non-standard work. So what are the consequences of workplace fissuring? Well, essentially, the consequence is that the lead business or the corporations of the last century no longer hire that many employees. Instead, what they're doing is buying services from other companies, and those companies buy services from other companies, and so on. And this sets up a lot of competition at all levels until the companies in the lowest tier can't afford to pay benefits and decent wages to their employees. Dr. Will describes a number of approaches to resolving this, both regulatory and non-regulatory, but I'll leave that to you to read the book and learn more about that. In the context, however, of total worker health in a fissured economy, I'd like to go back to this integrated workplace safety and smoking cessation study I described earlier. And I'd like to talk about the reasons for high rates of smoking among production employees and managers, and consider that work itself, especially high-strain jobs with high demands and few opportunities to control the nature or the pace or conditions of work, actually contributes to poor health behaviors. Jobs with lots of psychosocial stressors, such as those that I've listed here on the bottom of the slide, have been consistently found to result in high levels of psychological strain or stress, which many studies have demonstrated is associated with high rates of cardiovascular disease, mental health disorders, and musculoskeletal injuries. So if thus as was described by the first two speakers, the conditions of non-standard or precarious work, including unsafe workplaces, low wages, insecurity, no benefits, exploitation, are actually the converse of those that define healthy or decent work as defined by the International Labor Organization that I've listed here. So now I'd like to move a little bit to the context of our Center for Healthy Work. In the long run, we recognize that our vision of turning unhealthy work into healthy work will require changes in social norms, which are not easily or quickly altered. By the social ecological model and the important role played by the social determinants of health, as Dr. Barron described earlier, our work is focused on building community and organizational capacity for action via networks and partnerships. The center investigators are currently involved in two interrelated projects, each of which I'm going to briefly describe along with their very preliminary findings. The Greater Lawndale Healthy Work Project is a joint effort of investigators from two divisions in our School of Public Health, Community Health Sciences and Environmental and Occupational Health Sciences. This project is focused on two high-hardship Chicago neighborhoods and building on Dr. Hebert Barron's previous community-based participatory research. In one of these communities, this project seeks to build community capacity for recognizing worker health as an important determinant of community health, leading to the development of effective community-based interventions. So how will they do this? Basically, this is a community-based participatory research project which is taking place in partnership with community organizations and community health workers, as Dr. Barron described, who are based in each of the neighborhoods. The team is using multiple methods to conduct a community health assessment in years 1 and 2. I've listed some of these here. The results will then be used to inform an intervention mapping exercise, after which interventions will be designed, implemented, and evaluated in years 3 through 5, led by community researchers and partners again. Part of the community health assessment involves a sorting and rating exercise, which starts with a focal question answered by a wide range of community members. I've listed that focal question here. When I think of my work situation or people who live in my community in similar work situations, one way work impacts our health, good or bad, is, and then people filled in the blank. This generated 259 statements, which were then reduced to 65 items. I've given a few examples here, which community members were then asked to sort into categories, and then asked to rate. First asked to rate whether the item was true for most or not a lot of people in the community, and then second, whether the item affected a lot or not many people in the community. Using cluster analysis to evaluate the sorting results, it appears that work can have both positive and negative impacts on community health. Basically, the dots represent statements, and the closer the dots are together, the more often they were sorted together, while dots that are further apart were less likely to be considered related in the sorting exercise. I should note and emphasize that these results are very preliminary, but this first look also suggests that there are a number of important negative impacts of work on health in these communities, including some of the things we've already described: low wages, stress, exploitation, abuse, negative family effects, and others. Again, I must emphasize it's a very preliminary first look at the rating data. Using a pattern match display to examine the clusters identified in the sorting exercise, stress both affects a lot of people in the community and has a lot of impact on community health. On the other hand, no support for workers with children was perceived to affect a lot of people, but did not have such a large effect on the health of the community. At the other end of the spectrum, good work opportunity was not experienced by a lot of people in the community, but was also perceived as not having much impact on community health. And the correlation coefficient that's listed at the bottom, 0.81, indicates there's a relatively strong and positive association between community prevalence and health impact overall. The second project, the Healthy Communities Through Healthy Work project, which is being conducted by our outreach team, also involves investigators from community health sciences and environmental and occupational health sciences. This project builds on Dr. Welter's public health practice background and close connections with local and state public health departments, as well as Dr. Zanoni's long-term relationships with worker centers. This team is seeking to facilitate change and sustain a culture shift that leads to greater health equity for people in precarious jobs. Informed by the social ecological model, they are trying to build multi-level strategies that lead to systemic changes. How will they do this? The team is conducting interviews with a wide range of organizations at multiple system levels and in multiple sectors. And they're seeking input on how health and work are defined, what leads to or prevents healthy work, and what initiatives are currently underway that could lead to or promote more healthy jobs. The results of these interviews will inform the creation of networks or learning collaboratives that will identify gaps and opportunities for collective action. A few early findings, and I should emphasize these are very early. The team is still conducting interviews and identifying additional organizations to interview. But a first look suggests that several things. One, efforts to change the nature of work will likely require efforts at multiple levels of the system. Organizations do not appear to be working across the different sectors. And there does appear to be interest in addressing precarious jobs or non-standard employment, but it might be necessary to change the perspective and reframe the question from work as an individual problem to an understanding that work is actually a public population or a public health issue. The team has also identified a number of different products such as databases, briefs, fact sheets, and best practice guides, and several types of initiatives, as I mentioned earlier, such as learning communities or perhaps an advocacy learning institute, where they might be able to offer mini grants to support participation as methods for bringing about change. That concludes my presentation. Again, I'd like to thank NIOSH for arranging this webinar and for the opportunity to share the work of our center.
Thanks very much, Dr. Brosseau, and my thanks to Dr. Barron and Dr. Pana-Cryan for exceptional contributions to today's webinar. We'd invite all of you to enter some questions for our speakers today. We are happy to take questions. A few have been submitted, but happy to receive some more because we do have about 15 to 20 minutes left. And I will start with the questions from the audience, and then I have a couple of my own that I would like our panelists to weigh in on if we have time. So the first question appears to be for the Center for Healthy Work, but I think the question arrived when Sherry was speaking, so I'll just throw it out there both to Sherry and Lisa. Is the CHW training available online, or are there resource materials for the program available? And Sherry, we'll start with you.
Yeah, so the community health worker training program I presented is, it will be available. It's not available yet. We're just refining some of the activities based on our last testing and doing some evaluations, but we hope sometime later this summer to have it available. And you can contact NIOSH to find out how to get it from me.
Yeah, we'll be happy to pass that along and make it available as it's ready to go, Sherry. Thank you for that. For those of you who want a reminder as how to reach the Total Worker Health Program, our email address is simple. It's twh@cdc.gov. The next question came in for Lisa. Lisa, do you have information about the tool that was used to measure the safety climate you referred to in your early part of the presentation?
Yes, but I would, again, they should contact you, and I'm glad to share more information about that. It's actually been used in, it uses many of the same constructs we've used and published in our small business research that I've been doing with David Parker for the last few years, but I'm glad to share the resources for that.
Great, thanks for that. There are also a number of climate surveys, workplace organizational assessment tools on a number of our Centers of Excellence websites, and specifically the University of Massachusetts Lowell has a very good climate survey tool that's validated and widely used, and it's really a great starting point for organizations who are trying to assess their organizational climate, their safety climate, some of the cultural elements, the organizational questions that need to be answered, so you can identify where the challenges are. And the SafeWell guidelines that have been developed by Harvard also have a number of assessment tool opportunities as well. A next question comes in asking about the best resource for workers when it comes to this field. And I'll open that up to any person or any of our speakers on the call. Is there a resource for workers when it comes to those trying to sort of, stake out their own health and safety needs in this sort of new way we work in non-standard employment? Or is there a website or manual?
So this is Sherry Barron. I'll answer first. OSHA has a lot of resources for workers about workers' rights and the laws on their website, so that's definitely a resource. The other thing that I would suggest is that in many cities throughout the country, there's what's called worker centers. So those are centers set up to advocate for workers, and they have a tremendous amount of information and resources. Some of them do training for workers, and those would be good places to look. For the more professional non-standard workers, I know there's increasing numbers of sort of associations of freelance workers and other workers like that set up that also provide information. So it probably depends a little bit on the city that a person's located in, and bigger cities have more resources than some of the smaller ones.
Great. Thanks for that, Sherry. Rene or Lisa, any comments that you would want to add to that? It's perfectly fine if you don't have any.
Casey, this is Lisa. Yes, I would also suggest that they might contact the education research centers that NIOSH supports. Many of them have outreach programs that do collaborate with worker centers and unions and other organizations to do worker health and safety training. The one in Chicago and several others have long-standing relationships with worker centers. So they may also be a resource.
Yeah, very helpful. And folks, for those of you who are not aware, NIOSH funds a number of education and research centers for occupational safety and health around the country in academic settings. You can just Google NIOSH ERCs, NIOSH ERC, and find the network of education and research centers around the nation. On a similar note, someone asks about the role that employers play in community-based occupational safety and health interventions. And unfortunately, many employers don't have a significant role there. But Lisa, is there anything you would want to add about the role of employers, or where we would sort of like to see that progress?
That's a very good question, and it's one I continue to ask my team. We are aware that there are what one might call high road employers, and meaning those who are doing their best to offer the kinds of benefits and wages to all of their employees, whether they're in standard or non-standard employment relationships. And I know that there is going to be an attempt, at least by the Healthy Communities Project, to reach out to some of these high road employers, to interview them about their perspectives and their approaches. So, and I do know that there are, I believe there are a few employer groups or business associations that are affiliates of the NIOSH Total Worker Health program, and many of them have similar interests in trying to make a difference for workers in workplace settings.
Yeah, thanks for that, Lisa. You're exactly right. There are a number of organizations that have been designated Total Worker Health affiliates who are community-based or are occupational series-based that have really placed an emphasis on looking at the broader working conditions for people, not only in one employer but in large segments of occupations or industry. So for folks who would like more information about the Total Worker Health Affiliates program, you can just simply go to our own website or Google Total Worker Health Affiliates. Many of you on the call may even be eligible to have your own organization considered for affiliate status if you'd like to collaborate more deeply with our program. Here's an interesting question, and I'm certain our speakers will have some thoughts on this, and that's where the most significant research gaps are when it comes to non-standard work arrangements and their impacts on health. And I'll just ask each of you to give that some thought, and we'll start with Rene. What your thoughts might be on some of the largest research gaps in this area, and then we'll ask both the other speakers to chime in as well. Rene?
Thanks, Casey. I try to present some of our initial efforts in terms of better understanding taxonomy. So I will consider that part of the research gap, that we're trying to come up with a scheme for better understanding and categorizing these, increasing types of non-standard arrangements. What specifically are the characteristics of those, and how does it help us better understand what's going on? So certainly in terms of taxonomy, in the way that I've tried to describe, we need additional research. Then in terms of the research efforts that I presented on, those mostly have to do with let me start again. Those mostly have to do with some of the things that we had already kind of suspected, the easier, if you will, hypothesis to test. I think we're still lacking kind of like models of sorts that can guide us in terms of, again, how these different characteristics affect the incidence and severity, again, of safety, health, and well-being outcomes, so the bad outcomes, incidence and severity, or how they advance safety, health, and well-being. So kind of putting it all together, the determinants and the consequences, the potential mitigators. We have been looking at some existing models from Europe and Canada, trying to take the best pieces of them. But certainly, again, comprehensive models that help us understand how the pieces fit together would be something that we're very interested in.
Great. Thanks, Renee. Sherry, have you given any thought to where you see the largest research gaps in this study of health and non-standard work?
So, I think given the rapid growth of non-standard work, one could say that it's all gaps. That we need to do a lot. But what I would think is a couple of things. One is, as we all discussed, it's a very heterogeneous category, including higher wage and lower wage workers, people in different kinds of sectors, and so getting a better handle on what the similarities and differences are across those different categories would be important. But I think the most important thing is beginning to explore approaches to interventions, because I think to accomplish this, we really need to think in different ways than we have traditionally as occupational safety and health interventionists, thinking mainly about worksite interventions. And so the gaps, I think we really need some pilot projects and other kinds of programs, trying to incentivize some employers that might be willing to collaborate with community organizations or others to begin to see what works and doesn't work in terms of trying to reach these workers.
Yeah, great. Thank you for sharing that. It really emphasis on the need to develop interventions. If I were to look at the incoming requests that make their way to our program and to many parts of NIOSH, is that folks want solutions. Folks want evidence-based interventions that they can try in their own setting. So appreciate that. Lisa, thoughts on where the largest research gaps remain?
Well, I guess I would agree with Sherry. There's lots of them. And they're probably at all levels, from surveillance and etiology to interventions and dissemination. One of the first sort of strategic planning meetings we had with our center, we came away realizing that what we're really looking for is a complete change in the social norm of work and employment in the United States. And, the best example I can offer is think about what happened with smoking over the last 20 to 30 years. That wasn't changes just in any one place or at any one level. That took sort of a whole bunch of different things to happen, and it took a long time to bring about our perspective that, especially smoking in the general environment around us is not acceptable. And I think we need that same sort of change in social norms or sort of common understanding of what is work and what is fair, decent, healthy work. And we don't have that understanding in the United States, except maybe in pockets. But there is a lot happening. There's a lot of movement towards increasing the minimum wage. There are a lot of things happening in terms of policies, mostly at local and maybe state levels. And that is sort of what happened with smoking, is that a lot of things happened in states till it became clear we needed a bigger picture approach to that. So I guess I would suggest that what we need to understand is what combination, not just which interventions, but which combination of interventions is going to make this change in our perspective as to what people deserve as a healthy job and healthy life.
Great. Thanks for that. Here's an interesting question. One of our listeners today commented that they're happy to hear about the development of total worker health training for community health workers, especially when some of the standard routes for reaching workers on these topics are disappearing. But they ask us to chime in on our thoughts on the utility of developing total worker health training for public health professionals. And I will just take a moment to answer that question. I couldn't agree with you more. As you know, Total Worker Health really advocates for a very broad approach to occupational safety and health. It looks beyond just what happens in the workplace, but really its connection to the broader community, really to population level, organizational level approaches. And we're happy that one of the major products and projects right now underway in our own team within NIOSH and Total Worker Health is to look at workforce development, specifically around delivering training in the form of certificate programs for total worker health professionals or others in occupational safety and health and public health who want to learn more about the intersection of work and working conditions and health, and using that insight to develop programs to improve safety, health, and well-being outcomes for workers. So we have a number of universities that have already started certificate programs in total worker health, and a number that are under development now. So you will be hearing more from the Total Worker Health Program soon about ways that you can enroll in, sign up for both continuing education as well as more formal certificate and eventually degree programs in the field of total worker health. Here's, I think, a fairly quick question that came along that I want to pose for the group now. And one of those is refers to this concept of gig economy jobs, such as ride-sharing service drivers, the Uberization, if you will, bike messengers. And the writer says that these can be dangerous. So how is worker safety impacted when some organizations classify gig workers as independent contractors? And how does that translate into poor safety outcomes? And are there any additional thoughts on the gig economy itself? And I might just add in the question that I hear frequently about this is, aren't there some benefits to the gig economy? So where do the flexibilities that come from some of these forms of employment intersect or collide with some of the negative health impacts? So Rene, we'll start with you, and then we will ask the other two to chime in as well.
Thanks, Casey. I think the last thing you mentioned, where are some of the positive impacts, perhaps, or positive elements? How can we assess those? So, one thing that I didn't have time to talk about is that, we want to understand, of course, why employers do what they do in terms of non-standard arrangements, but also why workers, the ones who actually choose non-standard work arrangements, why do they choose them? And that's why it's important, for example, to understand the demographics, to understand where in the life, work life of a person, the non-standard arrangement comes. In other words, an independent contractor might report better health and less stress because they already had a career and now, they have retired, perhaps have a pension from a traditional employer, and now they could do their own thing. That would be a completely different story than somebody who is basically stuck with his, low-paying perpetual gigs because they don't have a choice. That's not their first preference. So when they're asked why they do what they do, they report that perhaps this is a way to get a permanent job, or this is a way to a higher wage, or what have you. So definitely research gaps that need to be filled include the reasons why employers choose these gig or other not traditional arrangements, but also why workers choose them. And is there, like you said, any benefit in those arrangements from the worker perspective? In terms of independent contractors, I would say that in terms of the gig economy, at least the legal issues have not been settled in terms of how the gig platform acts as an employer or not. So again, in terms of the independent contractor, they lack some kinds of legal coverage, but that's not necessarily a detriment in terms of safety, health, and well-being, depending on what the specific situation for an independent contractor is. So I can leave it at that for now.
Great. Thanks for that. We just have a couple of minutes left, but I will ask Sherry to chime in and add any thoughts to what Rene had to say or any additional closing thoughts. Sherry?
Well, I would just say, flexibility is great, but it involves a person being in the economic position to take advantage of the flexibility, and many people in flexible jobs aren't in that position, so flexibility turns into the workers need to overwork themselves as
right.
opposed to an employer. So, I think flexibility has to be used cautiously.
Yeah.
And just, saying again that public policy in many cases may be what's needed. I mentioned quickly the New York City new law to protect freelancers. And, it may take laws like that protect people in that more independent contract position against being abused.
Great. Thanks for those final comments. Lisa, a chance also for you to respond and any final comments for the group today.
I don't know a lot about the gig economy other than what I've read mostly in the popular literature, but I will say that the issue of insurance is always one I am concerned about. I get in a car driven by someone and it's their personal car. They don't probably carry the kind of insurance that's needed to ensure that I'm protected if we're in an accident. And I've read stories where that's been the case. So I think when we take advantage of these online platforms for the gig economy, the repercussions with respect to protections for people, both those being served and those who are employed, so to speak, or doing the work, we have to think really broadly about the fact that there's a lot of things that can go wrong, and if they go wrong, there has to be protection for that. So there's a lot more to be studied with respect to the gig economy, and it's obviously growing. I think it has some benefits, and it also has some downsides.
Thank you very much. And folks, we are at the end of our 90 minutes today for today's webinar. I'd just like to again thank all of our three wonderful speakers. So with that, we'll close today's session. Thank each of you for joining. Thank our wonderful speakers, and ask that you have a safe and enjoyable 4th of July holiday. Take care, and so long from NIOSH Total Worker Health.